Good morning, dear audience. Please let me present my results and my ongoing projects. My PhD topic is the surgery of the pelvic organ prolapse and female stress urinary incontinence. My name is Júlia. I am a PhD student and a resident doctor at the Urology clinic. My mission is to reduce the complications of the surgical treatments, and my vision is to formulate recommendations for surgical treatment in terms of the indications, contraindications, and the patient selections. Here you can see one of my finished projects and my two ongoing projects, which I would like to show you today. The first one is about the safety and efficacy of the vaginal implant surgeries in terms of the pelvic organ prolapse. It's a meta-analysis and a systematic review on a large population. Why it's important? Because 1 in 2 women over the age of 50 have a certain extent of pelvic organ prolapse. Around 11% of the women have a surgery for pelvic organ prolapse by the age of 80, and in many cases, an implant surgery required to treat the condition. With implants, we can achieve an excellent anatomical correction, but there are some complications. And the increasing number of the complications was the reason why FDA has issued several warnings regarding the vaginal implants in terms of the pelvic organ prolapse surgeries. Several countries completely banned the use of vaginal implants. However, the guidelines and the recommendation are not clear when to use or when to avoid the use of these implants. Our aim was to compare the safety and efficacy of the female pelvic organ prolapse surgeries with versus without vaginal implants. Pelvic organ prolapse has a significant impact on the patient's quality of life. This is why it's so important to find a balance between the efficacy and the safety in case of these surgeries. The question was whether there are any differences regarding the complications and the efficacy between the patients who undergo pelvic organ prolapse surgeries. The population was the females who undergo these surgeries. The intervention group was the group with implants compared to without implants, and we analyzed the complications and the efficacy, which we mean anatomical success. Finally, 77 articles were eligible to data extraction. And finally, we categorize the complications and the efficacy, and we separate the complications for functional and non-functional ones. First, you can see the multivariate model analysis of the non-functional complications. We measure the outcome in odds ratio, and I would like to highlight the erosion and the bleeding complication, which was significantly higher in the vaginal implant group. And erosion was the leading complication, which we think that it's implant-related. You don't see heterogeneity in this forest plot because it's a multivariate analysis, so the heterogeneity was pretty low because of the statistical model. Here you can see the functional complications, and I would like to highlight only the de novo stress urinary incontinence, which is higher in the implant group. And you can see the anatomical success. The anatomical success was more than 3 times higher in case of the implant surgeries, which it means that the surgeries with implants are very, very effective procedures. We analyzed the reoperation rates with the univariate analysis, and we separated to reoperation due to complication and efficacy. Here you can see the reoperation due to complication rates. It's more than 2 times higher in case of the implant surgeries. But the reoperation due to recurrence was higher in the native tissue group. So to summarize our analysis, it was a very extensive analysis of the complication with high-quality studies on a large population. There are some limitations, the rare events, and the heterogeneity because of the different implants and the different vaginal compartments. We conclude that pelvic organ prolapse surgeries with implants are more effective procedures. The reoperation due to complication rate is acceptable, and the difference is clinically not relevant, and the leading complication is erosion. For the practice, we should revise the vaginal implants, and we should fit the guideline for the daily practice. We should select the best target population. For the research, we should design RCTs, and we should analyze the prognostic factors. This manuscript was accepted in a D1 journal. And based on our first project, our second meta-analysis, we would like to investigate the risk factors associated with the erosive complications after female pelvic organ prolapse surgeries. The background is pretty same, but here we would like to identify the causes and the prognostic factors which predispose to mesh erosion after the vaginal pelvic organ prolapse surgeries, because the erosion was the leading complication in our first analysis. The question is, which is the subpopulation of the patients where we shouldn't use vaginal implants? The population was females who undergo vaginal implant surgeries with implants. We analyzed the risk factors, and the outcome was the erosion. The clinical implication is that we would like to decrease the erosive complication rate and increase the safety of these surgeries. We hypothesize that there are specific risk factors associated with erosive complications, and if we analyze these risk factors, we can reduce the occurrence of erosion rate after these surgeries. We use the population and the outcome in the search key. Finally, 36 articles were eligible for data extraction. We finished the data extraction, and now we're waiting for the statistical results. The third project is investigating the risk factors associated with complications of the female stress urinary incontinence surgeries with the synthetic slings. Why it's important? Because the prevalence of the female urinary incontinence varies 11 to 62%, and majority of the cases are stress urinary incontinence. And FDA has issued several warnings, not only for the pelvic organ prolapse surgeries with vaginal implants, but also the stress urinary incontinence synthetic sling surgeries. Some countries also limited the use of vaginal implants in case of the stress urinary incontinence. But the guidelines recommend to use these slings in case of the female stress urinary incontinence with a high level of evidence. So we would like to identify the causes and the prognostic factors which predispose to complications of the female stress urinary incontinence sling surgeries. The question is, which are the risk factors can influence the complications associated with the sling surgeries? We use the population as females who undergo a synthetic sling surgeries. We analyze the risk factors, and the outcome was the complication rate. We would like to decrease the complication and increase the safety of the surgeries by potentially eliminating the risk factors. We think that subarachnoid sling surgeries are still safe and effective procedures to treat this disease, and there are correlations between the risk factors and the complications. We use the population and the procedure in the search key, and now we are ready with the Prospero, and maybe we can submit it. Summarize the project. I finished the first one, and I worked the two others. One in case of the pelvic organ prolapse surgeries, and one it's about the stress urinary incontinence surgeries. Please let me close my presentation with a quote from Queen. But it's been no bed of roses, no pleasure cruise. I consider it a challenge before the whole human race, and ain't gonna lose. We are the champions. So, thank you, my friends.
Congratulations to nice presentation.
Thank you so much.
I'm not gynecology, so I have no clue, but so I would like to ask about your result about bleeding. Was there some information about severity? What should we imagine? Because you also showed that bleeding was increased in your first project. So I would like to know, like, what was the severity, and why are you not including this outcome in your second project as well?
Severity, what?
Of bleeding.
Of bleeding. It's usually it's a little vaginal bleeding, okay, and it's associated with erosion. So it's not independent from erosion. If you have erosion, you have a vaginal bleeding. In many cases.
So it's not like hemodynamically significant?
No, it's not a serious complication. It's a vaginal bleeding, we mean that. And most of the articles, the definition is same, the vaginal bleeding.
Congratulations, Júlia, for the publication. My question is related to your first and second project that you mentioned that in the implication that the most targeted population. What are these patient characteristics that make a woman eligible for this kind of implants? That you mentioned also in your second project that you are investigating these factors, but only for erosions.
Only for erosion complication, because this is the leading complication and most of the articles analyze this. And please let me turn this question. When we shouldn't recommend to use vaginal slings, which population we shouldn't use this? We don't recommend to use in a very young patients who are sexually active, because if the patient sexually active have a higher chance to get to erosion. And we don't recommend to use vaginal slings in a very elderly patient with a narrow, thin vagina. We don't recommend to use these procedures mostly in first line, so maybe it's a second line surgery. And I think we don't recommend to use with comorbidities like diabetes mellitus and other connective tissue disease. So we would like to find these target populations, and we would like to analyze this very.
Thank you.